All right, welcome to week 7 lecture. We're going to start with last week's exam, which I was extremely impressed with how everyone did. Overall, as a class, the average was a 95, the low score was a 76, and the high score was 100. So strong work. Everyone did a really nice job on that test. Okay, and everyone's able to see the test, correct?
Yes.
Okay. So question 1, what type of communication depends on the 5 basic senses? It's nonverbal. Which of the following is not true about effective communication for the patient undergoing surgery? And it's patients under the stress and anxiety of the upcoming surgery are better off not communicating their feelings or their emotional and physical needs to the healthcare team. Question 3, which of the following demonstrates good communication while in surgery? Understanding signals and gestures. You will all become very proficient at doing hand signals during surgery, whether it's communicating with your circulator, whether it's communicating with a teammate or a coworker about breaks and lunches. Effective communication can influence, and it's D, all of the above. Which of the following is not true about using cliches? They reduce the patient's anxiety. Which of the following is a characteristic of a good communicator? And that's D, focuses on the speaker. A patient says, "I wish I were dead." Which of the following is the most appropriate response? That's A, this must be a very difficult time for you. What type of communication depends on the abilities to read, write, and see? And that's written. Blank is an example of a block to therapeutic communication. Defending. Because a patient's records are legal documents, miscommunication causing inaccurate information to be recorded on a patient's record can lead to lawsuits. Is there something you'd like to talk about? Is an example of using broad, open statements. Paraphrasing what was heard helps to ensure that messages are properly received. Which of the following is not a goal of communication? That's to criticize the other person. Supply requests and doctor's preference cards are examples of what type of communication that enable other hospital departments to relate to the surgical suite. That's requisitions. Which of the following is not a characteristic of a social relationship? It's goal-directed. The social level of Maslow's hierarchy of human needs influences affection, love, acceptance, kindness, belonging, intimacy, and friendship. You're shaking, you seem upset, am I wrong? Is an example of sharing observations with the patient. Which of the following is not a true statement about psychosocial stress? All patients react to their fears and anxiety in the same way. Which of the following is not an essential component of effective communication? That's feelings. Which of the following is not a block to communication? Are you saying that? The blank level of Maslow's hierarchy of human needs includes approval, recognition, prestige, and status from others because of an individual's actions. That's ego. Communication is the process by which information is exchanged between individuals through a common system of words, symbols, signs, or behavior. Which of the following is not one of the components of effective speaking? And that's listen only to verbal feedback. Blank communication is sent in ways other than by words, nonverbal. Which of the following is not a positive way of coping with stress? That's shallow breathing. Obviously, you want to do deep breathing. Relationships benefit from which of the following? Effective communication. A blank relationship is guided by ethical code and policies of institution, along with common courtesy and good manners. It's professional. Which of the following is an appropriate response to patient fear and anxiety? Helping the patient with breathing techniques? Which level of Maslow's hierarchy of needs is the most important for the surgical team to provide to the patient? That's correction of physiological problem. Which of the following is not a purpose of communication among hospital team members? And that's to entertain each other during surgery. I can tell you, as you get farther and farther along in your career, there may be cases that seem monotonous or boring, and at that time is when you kind of let your guard down, and the surgeon may have the music up loud, you may be telling jokes, you may be laughing. In this instance, I want you to come back to this class during this time and remember, think about if that was your patient's family member on the table. Now, the surgeon can blast music. You have to stay engaged and focused in your surgery, okay? Again, it is those times when we become complacent that errors happen. The wrong implants get put in. Something contaminated may touch the surgical field. Whatever it is, you have to stay focused and engaged in what you're doing to provide the best patient care, okay? Blank is a state of extreme difficulty, pressure, or strain that can cause bodily or mental tension. That's stress. To listen effectively, focus on the message, not the speaker. The correct order for Maslow's hierarchy of human needs from most basic to highest is physiological, security, social, ego, and self-actualization. A therapeutic relationship is between healthcare team members and the patient's family. Blank includes any words or actions that may cause discomfort to another individual, including staring, telling sexual or racial jokes, and making offensive remarks about an individual's appearance, and that's sexual harassment. Which of the following is not outlined in a healthcare facility's policies and procedures to address and resolve conflict among staff members? And that's the RAND and position of staff members. Communication can best be described as sharing of information between individuals or groups. Healthcare facilities should have zero tolerance for disruptive behavior, whether that be sexual harassment, bullying, etc. It is challenging to diffuse a disruptive situation, particularly if you are the target. It may be helpful to try to find some truth in what is being said and to agree with the angry person. And at times, if you have a surgeon that is absolutely furious for whatever reason, maybe their case was delayed, maybe the turnover time was lengthy, maybe they don't have the right instruments, maybe the case is just tough in general, and they're aiming their frustration and anger at you, at times it is best to say, I understand you're frustrated, and this should be unacceptable in patient care. Whatever it may be, they may be yelling at you, but it's not about you. It's about the situation. So remember that in your career and in your field, is at times they're stressed, and you may be, that sounding board that gets their anger and frustration directed. Noise population in the perioperative workplace can interfere with critical activities. The Environmental Protection Agency recommends that noise levels should not exceed, that's 45 decibels. Conflict may be effectively managed when both parties have some of their needs met in a win-win strategy. Which of the following best describes a win-win strategy? And that's collaboration. One's cultural background and beliefs can influence attempts to resolve conflict. Which of the following may be a useful resolution technique? That's acknowledging culture. Communicating your needs and feelings clearly is an example of assertive communication. A timeout communication that must occur immediately before an intended procedure in a healthcare facility is mandated by the Joint Commission. What is the most frequently cited root cause of Sentinel events? and that's ineffective communication. Accurate information about a patient's care, treatment, services, current condition, and any recent or anticipated changes as the care of the patient is transferred from one healthcare provider to another is handoff communication. We kind of talked about that last week. Make sure you're a good teammate and a good coworker and give a decent handoff communication if you're getting a break or a lunch. Which of the following is true of in-service programs? They allow departments to communicate policy, which I will tell you during COVID, policies and procedures were changing weekly at healthcare facilities around the Treasure Valley. The administration was trying to keep up with what was going on with national standards. And so those in-services can be pretty detrimental to your safety and to your knowledge of what's going on in your healthcare facility. These were all kind of additional questions. They were not in the chapter or not in the material, but it's all information I want you to know before you start classes with Mona and Eric in the fall, okay? You are in a surgical technologist program. As a CST, you pass instruments to the surgeon. And of course, how many more weeks are in summer semester? 2. Yay! All right. Excuse me. Okay, next I want to talk about PowerPoint presentations from last week. I absolutely loved them. Love them, love them, love them. If all of you are okay with sharing them as a class, we are going to get them in a folder and have them available during fall semester, the beginning of fall semester. It was interesting because there was a lot of similarities amongst you all. And I love that. Whether that means that type of personality goes into the surgical field, I don't know, but a lot of similarities amongst the class this year. Second thing, if your PowerPoint presentation has not been graded, that is because you submitted it and you did not email it to me, okay? If you do not email it to me by the end of the week, you will get a 0, okay? So we covered it in lecture, and I also made an announcement. Please email it to me. There is something wrong with Blackboard that it doesn't allow it to be properly downloaded. And I know a lot of you struggled to even email it because the file was so large. So there's just something quirky with the whole Blackboard CWI system with PowerPoint presentations. And I don't know if that's just this year because they updated it or what the issue is, but please, 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 I don't want to give anyone a 0. I hate zeros in the grade book. Please, if you do not have a grade in the grade book from your PowerPoint presentation, it's because you submitted it on Blackboard instead of emailing it to me. So please email it to me by the end of the week. All right, does anybody have any questions or concerns regarding the test from last week? No, okay. We will move on. I'm going to quickly show you the discussion board. Also for this week, so you want to read chapter 2 of the surgical technology book. That's pages 24 to 40. You want to print off the PDF document. Uh, 3A, and it's not in week 6 folder, my apologies, it's in week 7. Before this course started, we kind of rearranged some of the modules in the units. Complete the 3A readings, which is the Introduction to Surgical Technology book, pages 3A to 25. Complete your Cengage learning. Watch the AORN video. I guarantee you there's questions from the study guide on this test. And remember, at the end of the study guide are the answers to those questions. And I apologize, those dates are wrong. It does not open July 23rd and closes July 25th. So I will fix that as well. Okay, So here is the discussion boards. Here are the groups. Can everyone see the discussion board groups?
Yes.
Thank you. So here are the groups, okay? At this point, you pick whatever group you are in, go to the appropriate folder below the groups. You will see that it is blank. Create thread. Ta-da! Here's your case study, okay? Read your case study. Answer the 6 questions below in your thread. Hit submit. And then I want you to respond to 2 of your classmates. Add whatever input you want to add. And I need it to be well thought out, not just strong work, Joe, or whatever. Make sure that you're reading maybe your classmate has a different point of view. Maybe they've kind of experienced something like this. So anyways, does everybody kind of understand how to do the discussion board? Are there any questions, concerns regarding discussion boards? You guys are quiet this morning.
Hey, Mingo. Is everything for the discussion board due this Sunday?
It is.
Okay, thank you.
Yeah, unfortunately, we have to have everything turned in during the class before finals start. Oh, and also, did everybody get the, I think Jordan was telling me he made an announcement about the final review that's next Tuesday at 9 a.m. It will be recorded and we will post it, but we'd love to have as many people as possible attend just so that we have some interaction. If you don't understand certain concepts or certain material, that would be a great time to bring it up and discuss it before you start fall semester with Mona and Eric. So just kind of a heads up. I think, perfect, thanks Lindsay. I think it's from 9 to 1, 9 to noon. I think we planned between 3 and 4 hours just because we are doing it together. So Jordan and I will be inside of the lab at CWI, and we will be doing online collaborate just like we teach our classes. All right, I'm going to go ahead and move on to the material for this week. All right, everyone see Introduction to Surgical Technology? Is that a yes?
Yeah.
Perfect, thank you. I will tell you now, this exam is hard. There's a lot of, maybe it's me, I don't know a lot about legal and ethical words, material, information. This exam is hard. Please, please, please prepare before going into it. So do the module, read the book, know the material out of the book. If you don't know what a word means, which we will cover a lot of words today, please look them up in a dictionary, Google it. When you Google it, and I'll tell you, I had to watch YouTube videos on how to pronounce some of these phrases a couple weeks ago. If you don't understand a word, make sure that you put in there, what does justice mean in the medical field? And it will relate it to our field instead of just what justice means in the world, okay? So module objective. After completing this module, you should be able to explain surgical conscience and your legal and ethical responsibilities as a surgical technologist. Terms and definitions that we'll cover: ethics, Hippocratic, malpractice insurance, negligence, root cause analysis, and Sentinel Event. All right, accountability for personal actions and obligations. Within our society, people are legally accountable for actions taken in their personal and professional lives. Surgical technologists have legal and ethical responsibilities toward their patients. Surgical technologists, their employers, and members of the surgical team can be held responsible for negligence for actions taken or not taken in the healthcare environment. So I'm going to share a couple personal stories throughout my career that, what do I want to say? Maybe where I trusted the surgeon a little more than I should have, or maybe where I should have stood my ground. So maybe about 15 years ago, at St. Alphonsus, we started a program called the Lap Band Program. And we flew to OHSU and we watched a nationally known surgeon perform these procedures. And I flew with 2 other surgeons. And we came back and we started this program at St. Al's. And I will tell you, once you guys are in the OR, you'll understand time is of the essence, right? The more cases you do in a day, the more money that the facility brings in, et cetera, et cetera, et cetera. So you are always hurried. You are always rushed. It's not a leisure career by any means. You know, you're usually hustling all day long in your career. So we would do 8 of these lap band procedures by about 2 o'clock. And we would hop from room to room. So we had 2 rooms. So we would start in one room, start the case. As we were closing, they would bring the patient to the next room with another crew, and we'd bounce back and forth. And we could do these cases, I think, in about 24 minutes from incision time until the time that we closed. So we were super efficient and fast at what we were doing. The hard part is we didn't have enough instruments that are, and back then you could flash or autoclave instruments. So we were having to flash or autoclave some of our instruments. And there was something called a liver retractor. And it had a big bar that hooked on the side of the bed, and it would hold the liver up out of the way as we were doing this procedure. And so we would pull these instruments out of the autoclave, and they would be boiling hot. You couldn't touch them with your hands. You'd have to have towels to pull them out, then put them on your back table, and you would soak them in cold water to try to cool it down before the provider or the surgeon was ready to go. So I went and pulled out this liver retractor out of the autoclave, super hot. I'm trying to cool it down. Well, of course, the surgeon walks in and he's ready to go. Let's go, let's go, let's go. And I said, it's too hot. You've got to give it a couple minutes to cool down. I've got cold water on it. I've got cold towels sitting on it. His response was, I can handle it. Give it to me. Instead of standing my ground, which I now regret, I gave it to him, and he dropped it on the patient's stomach and gave her a 3rd-degree burn. And that burn was probably maybe 5 inches long. And at the time, we didn't realize how bad of a burn it was. So he picked it up and he's like, oh, that is hot. I said, I told you it is hot. So he went ahead, put it on the side of the bed. We continued on with the case, finished the procedure. And at the end, we noticed she had a massive blister on her abdomen. I will tell you that resulted in a lawsuit. I had to answer questions at a deposition. I had to write out everything that happened during the case. If I would have just taken maybe 3 more minutes and told that surgeon, let's just wait, it's too hot to handle, I could have avoided all of that legal type stuff. I will tell you, each one of you in your careers will be put in a similar type of situation. Maybe not that the instruments are hot, but something where maybe you are doing a neck fusion and the surgeon's NP or PA has to run to the office to go see a patient quickly. And he's drilling into the bone and he's like, hey, can you just go ahead and grab the drill? I've got the drill guide right here. Can you go ahead and drill? Another true story, I had a friend that this happened to, and she drilled right through the bone into the esophagus. You as a scrub tech have to hold your ground. No matter what you do, stay within your scope of practice and hold your ground, number one, for your legal backing, right? You don't want to get sued Number 2 for the patients. So for me, I could have saved that patient going through having to have her burn treated and everything else. The one with the esophagus, that patient was on a feeding tube, I think for like almost 2 months because of the hole in the esophagus. So you may feel like that surgeon is trusting you. Oh, that surgeon is trusting me. You know, my ego is growing. My self-esteem is growing, all this type of stuff. And you may feel like you're on cloud 9 and that this surgeon just thinks that you're right up there with them. Do not go outside of your scope of practice. Know what is within your scope of practice and stay there. You do not want to be in the middle of a lawsuit. You do not want to be sued yourself. The hospital, I believe, on each person, I think backs their employees up to $1 million. After that, you're on your own. Okay, so not a bad idea to also carry liability insurance as you get farther along in your career, but just kind of a heads up, stay within your scope of practice. It will save you a lot of heartache, and stand your ground when you need to for patients' issues. All right, next, objective 2, accountability for personal actions and obligations. This is continued from the previous slide. Surgical technologists must adhere to accepted standards, regulations, policies, and laws. CSTs are obligated to disclose details of their patient care and surgical procedure activities in written documentation and when called upon in legal proceedings, kind of like I experienced almost 15 years ago. And that's exactly what I just said. Because of possible legal consequences, all surgical technologists should acquire malpractice insurance. Your hospital will only back you for so much money. If you're involved in a lawsuit past $1 million, you probably want your own malpractice insurance. Objective 3, areas of legal responsibility affecting the surgical technologist. Guiding medical principles. So doctrine of foreseeability, the degree to which an action could be anticipated to cause injury. So this could be something like they're using an expired mesh or an expired stapler. Ager primo, literally the patient first, and this is the motto of the Association of Surgical Technologists. Doctrine of reasonable man, a patient's right to expect professional and technical personnel to perform their duties and meet the standards of other personnel involved in similar conditions. So this kind of goes back to what is the national standard of care? If a person had this type of inguinal hernia, what would 95 or 99% of the surgeons do to repair this? Doctrine of borrowed servant. The employer, normally liable for an employee's actions, is not held responsible when that employee is under the direction of someone else. And I don't know if you guys have read the material in the book yet, but it talks about captain of the ship. And that is mentioned, you will hear that in your career, that the surgeon is the captain of the ship. And so if something happens in the case and it was due to the surgeon telling someone to do something, or he led the case in that direction, he is the captain of the ship, and therefore he is legally obligated to be responsible for the outcomes. So it's not the hospital that's liable for your actions, but it's the surgeon because he told you to do it. Primum non nocere, literally, first do no harm, a guiding principle of the Hippocratic medical ethics. Respondeat superior, literally, a superior must answer. So employers are responsible for the acts and omissions of their employees. So when that burn happened, my manager and director both had to meet with our attorneys. So at St. Al's, our attorneys had to meet with them. The patient's attorney that was suing the hospital, my manager and director also had to meet with them. Res ipsa liquitour, literally a thing that speaks for itself. A defendant is guilty of negligence without the need to show direct involvement. Accountability and liability terms. Okay, so I'm going to cover some of these, but some of these are in your book. So I'll kind of hit some of them. So accountability, it's the obligation to disclose details for evaluation, commonly used to mean to be held responsible for, right? So we all have accountability in the OR. Assault. Before I get started, can anyone tell me the difference between assault and battery?
Can you hear me?
Go ahead. Yeah, you bet, Ray.
I think, isn't it assault is the threat of violence or whatever, and battery is when you actually do hit them or actually do cause harm to them, right?
Perfect. That's absolutely it. And I had no idea when someone was arrested on assault and battery, I just thought those two words went together. No, so assault is the act that causes the person to fear, and battery is the actual act of harming the person. Nice, Ray. All right, liability. So we all have liability in the operating room, liability to keep the patient safe. Corporate liability. So that's the liability of whatever company you work for. Personal liability. So that's your own liability, such as making sure that the patient is not harmed while they're under your care. So make sure you're not using expired suture or expired mesh. Product liability. So this has to do with, let's say you're using some sort of implants, whether it be screws or bars on a neurosurgery. Maybe they're doing a back fusion, and a screw breaks. So that's a product liability. Law and tort terms. Advanced directive, and we kind of covered this a couple weeks ago. So it's a set of written instructions that address the right of an incapacitated person to, of an incapacitated patient to self-determination. So what does that patient want done? Do they want to stay on life support? Do they want to have IV fluids? Do they want to have a feeding tube? Breach of confidentiality. So breach of confidentiality, and there's another one that I think is invasion of privacy. So breach of confidentiality, let's say that you had a patient that had a massive inguinal hernia, and it went down into their scrotum and just created this huge mass. And you're sitting at lunch and you think it's a great story to tell your coworker. That is a breach of confidentiality, right? Of course, because of HIPAA. Common law. Complaint. Confidential communication. Crime. Defamation. What is defamation? So slander. It can damage a person's reputation or good name. You will probably work with surgeons that are less than stellar in your career. I recently had a friend contact me and ask about a particular surgeon for a procedure. And my response was, I would recommend getting a second opinion. I think a second opinion would be a good idea. And here's who maybe I would recommend getting a second opinion from. I did not say anything personal about that surgeon. Nothing whatsoever. I wouldn't let that surgeon touch me. I don't want them touching anyone else, but I did not say that when I was asked about that particular surgeon. So there's a very PR way of saying, stay away from that person. Get a second opinion. I think this is who you should get a second opinion from. Defendant. So I was a defendant with the burn case. Deposition. That's when I went to a meeting and was questioned by attorneys. Expert witness. That is someone who is in a field and has had numerous years of experience, numerous amount of knowledge in that particular field, and they are classified as an expert witness. They can be called in on court cases to ask their opinion. A felony. Iatrogenic injury, excuse me. That is an injury that can be caused by positioning. So let's say the patient comes in for, let's say, maybe a vaginal hysterectomy, and the patient is placed up in lithotomy. If the hips are rotated too far out and not put in proper positioning angles, it will damage the nerves in the hips and can kind of make those muscles really ache after surgery. So that's an iatrogenic injury. Invasion of privacy. Let's say Tom Hanks is in my hospital. Let's say he gets COVID and he's in the ICU. And I want to get into his chart. You know, hey, I just want to see how he's doing. Is he intubated? Is he stable? That's an invasion of privacy. Okay, there's no reason for me to be in his chart. So again, in your medical career field, do not be in patients' charts or looking in patients' private stuff if you're not taking direct care of that patient. Lack of proper supervision. Let's say that a trauma surgeon, for example, has to run downstairs to see a trauma patient. And so he leaves you as a scrub tech in there and he's like, hey, I've already dissected out the cystic duct and the cystic artery. Can you just go ahead and clip those and cut them and finish taking out the gallbladder? So number one, that's way out of your scope of practice. You should never do that. Number two, you do not have the proper supervision to be doing that type of work on a patient. Libel, litigation, a misdemeanor. And again, all these are in your book. A plaintiff, slander, we talked about that one, and a statutory law. A tort, and it talks about tort law in your book. So any civil wrong independent of a contract and provides a remedy in the form of an action or damages. And there's intentional torts and unintentional torts. False imprisonment. Someone is wrongly accused and then guilty and placed in prison. A subpoena. A trial. A jury. Negligence terms. So let's talk about what negligence means. Failure to use care that a reasonable and prudent person would use under similar circumstances. So that's kind of what we talked about. What is the standard of care for this patient? Comparative negligence. Malpractice. So again, all terms that I want you guys to really understand and look up in your book. And if your book doesn't do a good job of explaining it, go ahead and YouTube it, Google it, all of that type of stuff. So comparative negligence can be, let's say that Dr. Smith is being sued for negligence. He can be compared to Dr. Jones. And what would Dr. Jones have done in this type of situation? Gross or criminal negligence. Incompetence. Was the surgeon incompetent in treating the patient? Maybe he did not treat them correctly because he was not trained how to treat that type of patient. All right, objective 4, Sentinel Event. Can anyone tell me what a Sentinel Event is? Anyone who works in the healthcare field will know what a Sentinel Event is. It is something you never want to be a part of, but most likely in your career you will at least once. An unexpected or unanticipated event, unrelated to the natural course of the patient's illness, in a healthcare setting that results in death or serious psychological or physical injury to a patient. Okay, so anything that happens in the operating room that's not expected. Let's say the circulator forgot to put the safety strap on the patient, and they put the patient in pretty steep Trendelenburg, right? So their legs are up and their head is facing down. And during the procedure, the patient slowly starts to slide towards the CRNA or the anesthesia person, and eventually they partially fall off the table. That is a Sentinel Event. A misidentification of patient. So when you have common last names, this can be a common occurrence. So let's say that we are doing a lap chole. So we're taking out a gallbladder, and our patient's name is Jane Smith. Let's say that Dr. Baresi is doing a hernia repair on a Janice Smith. So they both say J. Smith in pre-op. You want to make sure that you get the right patient, and that's your circulator. But that is something in the timeout that you can always double check. Incorrect procedure. So did they do the wrong procedure on the patient? Wrong site surgery. I guarantee you this has happened at every single healthcare facility in this Treasure Valley. They came in for a left knee scope, and somehow the right knee was done. Incorrect sponge, needle, or instrument counts. Again, I can guarantee you this has happened to every single healthcare facility in the whole entire Treasure Valley. The hard part about counting is that you count until you get the correct number. So you don't repeat count. I count, oh, correct number, moving on. If the sponge count is incorrect, I will continue counting until I get the right one, or until we figure out that maybe it was left in the patient. However, we are all humans, we make mistakes, and so incorrect counts happen, and patients can come back weeks later, maybe with an infection, and a lap was somehow left in the patient, or a 4x4. Burns, falls, or injuries. And I can definitely relate to the burns ones. Burns happen. If you're doing a laparoscopic case, the light cord can sometimes be hot and burn through the drapes. Patients fall. Maybe the gurney's brake doesn't work, and so as they were moving over to the operating room table, the gurney moved and shifted, and that patient fell on the floor. Abandonment. Let's say that, and I will tell you this will happen too. Here's a little test question. Amber, the CST involved in a colon resection, has to leave to pick up her daughter from school at 3 p.m. She knows that if she leaves without relief from another CST, she could be charged with, and that's abandonment. Because most healthcare facilities in the Treasure Valley are short-staffed, sometimes you're not relieved on time, and that's extremely difficult, especially if you have appointments such as picking up your daughter, or maybe you have a doctor appointment or something like that. A little word of wisdom: if you get off at 3, don't make doctor's appointments at 4. make them like at 4:30 or 5, or take a day off to do doctor appointments. You just never know who's going to call in sick or how short-staffed you'll be, and you cannot leave that patient. If you leave, that's abandonment. Incorrect positioning. So that's kind of like what I talked about earlier. Does the knee line up with the shoulder? Did you over-rotate the hips? Was the arm not placed properly and then caused damage with the nerves in the shoulder? Improper care of specimens, including loss or misidentification. And again, this has happened in the past at every single healthcare facility. I kind of talked about it a couple weeks ago. Sometimes the specimen gets put on the back burner because other stuff is going on. You fold up your drapes, throw them in the trash, and guess what? Either you can catch that specimen, you can catch that mistake in time and try to retrieve that specimen, or that specimen goes to the trash compactor and it's long gone. And then you have to go to risk management and try to sort out a root cause analysis. What could you have done different to prevent that issue? Incorrect drugs or incorrect administration. So perhaps the wrong medication was given on the field. Use of defective equipment or instruments. Improper care of patient's property. Sometimes when we have a patient, especially a trauma patient, come to the operating room, they'll have all their clothes, maybe dentures, glasses, hearing aids, all that type of stuff. Make sure that that's taken care of properly, because the last thing you want to do is have a patient's expensive personal items come up missing. And when I say expensive, I don't mean a wallet, but dentures are expensive, glasses are expensive, hearing aids are expensive. So just make sure that you're responsible with those. Lack of informed consent. Did we make sure that the consents were signed prior to coming back to the operating room? A major break in aseptic technique. Let's say that a surgeon is impatient and they don't want to wait the proper time to make sure that the tests pass, saying that the instruments were sterilized appropriately. So they go ahead and use those instruments and then the test is done later, right? Or the results come back later from that test and it shows that the instruments didn't reach the temperature for the appropriate time to make sure that they were sterilized. That has happened in the past, again, at all healthcare facilities. Documentation errors. Did the circulator make a documentation error somewhere in the patient's charts? Failure to observe critical events and to take appropriate action. So if you saw something happen, maybe the patient, and I know this happened, I think back east somewhere, a patient carved his initials in a woman's uterus. He was doing a laparoscopic surgery and thought it would be funny to take the bovie and carve his initials. Inappropriate and it's unprofessional. Exceeding authority or accepted functions. So assault and battery. Breach of confidentiality, we talked about earlier. Invasion of privacy. If you have MVPs, and you'll probably all work on what they call them as MVPs. I wish we treated every patient as an MVP, but in all honesty, they will say, oh, hey, we're having, I don't even want to use anyone's names that we've worked on. Sarah Jessica Parker is coming in for a, let's say a breast implant. You want to be in the case. You want to know what's going on. You want to share this with your family and friends. Don't take the risk of losing your job and ruining your career. It truly isn't worth it. Defamation. Again, be professional in how you talk about surgeons and providers. All right. Objective 5, risk management issues and prevention practices. Minimize the risks to the patients. So make sure that they have on their safety belt, make sure that your irrigation is warm, make sure that the arms are strapped to the arm boards, because if you start to move the bed, the arms may fall off and cause nerve damage in the shoulders. Minimize the risk to employees. And so you want to wear lead if you're doing x-ray. Identify potential causes of sentinel events before they occur. So a big part of your job as a scrub tech is to put out the fires even before they begin. Implement policies and procedures to eliminate and reduce sentinel events. In the past, we have had staffing that didn't know how to correctly run certain equipment. So there's something called an Argon Beam, and it's used on trauma patients. If they have a huge liver laceration and they're bleeding, they'll take this Argon Beam, and it's truly like a high-powered laser, and we just cauterize the liver. It is used maybe once every 4 or 5 years. So we do an in-service on that Argon Beam once a year. As you can imagine, having an in-service once a year does not give an employee a really good foundation on how to run that piece of equipment. So sometimes that's hard. However, what we do is we implement policies that maybe we review the Argon Beam quarterly or maybe every other month. Establish procedures for collecting data, right? So root cause analysis. What could have been done differently to prevent the sentinel event? So the definition of root cause analysis: process for identifying the factors that are the basis for any variation in performance, including the occurrence or possible occurrence of a sentinel event. Focuses on systems and processes, not individual performance. So if you're involved in this sentinel event, risk management will try to ask you in your management to do a root cause analysis. What can we implement as a policy and procedure that will prevent this in the future? Risk management issues for healthcare facilities include reduced staffing. I don't know any operating room in the whole entire Treasure Valley that is fully staffed right now. I would guess 80% of our healthcare facilities have travelers right now, which makes it great for you as scrub techs when you're graduating, because you will be able to hand pick where you want to go. You may get offers from 5 different healthcare facilities because we are short-staffed and there is a shortage of scrub techs in the Treasure Valley. So it's good for you. It's tough though when you get hired, because sometimes you end up working longer than your shift. You have to pick up extra call, et cetera, et cetera. Patient safety. Employee rights. So can an employer make you work 24 hours because there isn't anyone to relieve you? And the answer is no. Prevention practices. Perform preventative maintenance of equipment. So in most healthcare facilities, Biomed does a yearly test on all equipment and put a little sticker on that it's passed, just making sure that it is safe for patients. Provide continuing education for employees. Most healthcare facilities will do a meeting once a month to provide continuing education. It could be on, how to set up the Wilson frame, how to use a NovaSure machine, whatever it is, but employees usually will keep their employees up to speed with equipment. Ensure that employees know location of and how to use emergency equipment. So we normally do a code course at least once a year, if not longer. Do we know where the code carts are? Do we know how to effectively run the code carts? Do we know how to maybe pop the locks on stuff to get epinephrine out? That type of stuff. Managing sentinel events. Notify proper authorities of sentinel event. So obviously this will go up the ladder quickly when there's a sentinel event. Your manager will be notified. The manager will then notify the director. The director will then notify the CNO and the COO, and obviously risk management department will be involved. Complete incident report outlining details of specific event and identifying witnesses. And your incident reports are all filled out on the computer now. Complete a root cause analysis, focusing on systems and processes that might have led to the Sentinel event. Develop an action plan outlining steps to reduce or eliminate the risk of a similar event happening again and giving the process to be used to evaluate the plan results. Submit action plan to the Joint Commission within 45 days of the event. So Sentinel events are kind of a big deal at facilities because Joint Commission gets involved. And if you have too many Sentinel events happen, Joint Commission, so we may lose our trauma status. I know that St. Al's used to be a level 1 hospital, but because we do not have a pediatric trauma surgeon on 24/7, on call 24/7, we lost our level 1, and so we're now a level 2. So I would bet that a Sentinel event occurred. Maybe a child came in as a trauma and we didn't have a pediatric trauma surgeon in-house. And that was a Sentinel event, and our level 1 accreditation was pulled. Objective 6, criteria used to establish negligence in court cases. So damage, dereliction, failure to meet standards. And again, so much of this has to do with national standards, or what is the standard practice of care. Proximate, the direct cause of injury or damage. Standard of due care. Terms related to credentialing. So we talked quite a bit about credentialing, licensure, accreditation in the program. Some of those questions will be on your national exam. So the credentialing is the process of establishing a minimum level of skills and knowledge for professional activity. So for credentialing, NBSTSA will be the organization that administers the national exam for you. Accreditation, the formal recognition of an instructional program as conforming with a set of standards. And the CAAHEP credentials programs all over the nation. So they are the ones that they are the ones that accredited CWI for this program. And with accreditation, then your students can take the national exam. So you will see other programs, even in the Treasure Valley, and I'm trying to think of some. I don't know about University of Phoenix, but we've had students graduate, or we've had coworkers graduate from other programs that weren't accredited. And because they aren't accredited, they don't get to take the national exam, and they don't get to work at facilities that require certification. Certification, documentation that confirms that one has met the requirements of and may practice in a field. Certification is voluntary and not mandatory. And Association of Surgical Technology will handle your certification after NBSTSA administers the national exam. So you will send in all your CEUs to AST every 2 years to keep up on your certification. Licensure. So as a scrub tech, we don't have to worry about licensure, but obviously nurses do. The granting of licenses to practice a profession ensures that individual is qualified and has met certain educational and training standards. Licensure is mandatory to practice a profession in which a license is available. And then registration, the act of listing qualified individuals in a registry. So there is an Idaho registry for nurses, and nurses have to, I think, pay a fee or pay a due every single year and make sure that they are registered with the state of Idaho. All right, we're going to take a quick break for about 5-10 minutes, probably about 5 minutes. So we'll be back here at 10:05, and then we will go over our next objective. Does anybody have any questions or concerns? All right, I'll see you in about 5 minutes. All right, can everyone hear me?
Yes.
Perfect. Okay, so I'm gonna kind of put our PowerPoint presentation on hold. I feel like we're kind of going through that super fast, so I want to go back and review. But I also wanted to share this case that happened in Boise, and kind of present, I guess, what could happen in the judicial system, especially when you have jurors who don't know a lot about the healthcare field. I was on a federal drug case maybe 5 years ago, 4 years ago, something like that, that involved the federal government. It was with a big drug dealer, et cetera, et cetera. And I was with 12 other jurors, right? Because 12 or 13, because they always picked 1 or 2 alternates just in case something happens with one of the 12 jurors. And I will tell you, I was a little disappointed in my peers, right? Because as a juror, you're supposed to be paying attention, taking in all the information, et cetera, et cetera. Out of those 12 jurors, and I think it was a week-long case, so we'd get there 8, and I think they'd let us go by 3:30 or 4. We'd come back the next day and listen to, all the information from both sides, et cetera, et cetera. There was one guy who was writing notes on a piece of paper. There was one that was sleeping. There was one that I think texted 3 out of the 4 days. Another one was on Facebook a large amount of the time. And we were the deciding factor on whether this person went to prison for a very lengthy amount of time. And so I thought in my mind, I'm like, I would hate to have some of these people as my 12 jurors deciding whether or not I'm going to spend 15 to 20 years in prison because they're distracted by other stuff. So kind of going back to this case. So this was a case that happened, and can everyone see this? The Justia US law?
Yeah.
Yes.
This is a case that I actually studied at Health Law and Ethics at BSU when I was going there. And I think it's a junior or senior level course. But I was also a cell saver tech and a manager at St. Alphonsus for the auto transfusionary system. So do you guys all remember when we took the tour of St. Al's, I showed you the cell saver machines, and they're machines that process blood. So you use your suction blood off the field. It is then spun down and you give back red blood cells to the patient with a very high H&H. So it's great for patients that are Jehovah's Witness, right? That maybe they won't take a blood transfusion. Great for trauma patients, especially where we have a severe blood shortage in the nation right now, and especially here in the Treasure Valley. It's great because you can not use those units from the blood bank. You can save those for maybe trauma patients. So anyways, in 2004, this case happened, and I just kind of want to read down through it, and I want to get your guys' opinions on it, okay? So Appellant B&B Auto Transfusion Services was involved in this case. It happened at Treasure Valley Hospital. All of you will be going to Treasure Valley Hospital for clinicals. On August 2nd, 2004, Lori Jones underwent lumbar spine surgery at Treasure Valley Hospital and died when an air embolus entered her bloodstream from the reinfusion bag. 2 anesthesiologists were on hand for the surgery, Dr. Thomas Lark and Dr. Deborah Jenkins, the relief anesthesiologist. They were under contract with Treasure Valley. And then it talked about, and here it talks about Jerry Kurtz, the certified cell saver technician who was employed by B&B, was also on hand for the surgery. Kind of talks about who owned everything, et cetera, et cetera. It talks about Jerry's training. I did know Jerry. She had come to St. Al's to do cell saver because at that time cell saver had a contract with them. I can tell you that on the reinfusion bag, it says do not use with pressure cuff, right? So as anesthesiologists, they would have seen that warning, whether or not they read it and processed it. Here's what happened during the surgery. Kurtz had processed the blood 4 times and had 500 milliliters of blood in the reinfusion bag to be returned to the patient. Dr. Lark placed the bag on the IV pole. Jerry Kurtz went to another room to manage a cell saver machine in that room. While Kurtz was out of the room, Dr. Jenkins relieved Dr. Lark so that he could take a lunch break. Dr. Lark left the room. Dr. Jenkins sought to speed up the infusion process. She found a pressure cuff and placed it on the bag. She later testified that she had not noticed the warning on the bag that specifically cautioned against applying a pressure cuff. According to Dr. Jenkins, when Kurtz returned to the room, she did not say anything to Dr. Jenkins about not using the pressure cuff. Kurtz claimed she told Dr. Jenkins a pressure cuff should not be used on the reinfusion bag. It is undisputed that no conversation took place between Dr. Lark and Kurtz after Dr. Lark returned from his break. When Kurtz noticed the blood had completely emptied from the transfusion bag, she tapped Dr. Lark on the arm to inform him the bag was empty. He asked her how long the line had been empty, and she replied she did not know. Dr. Lark then realized there was air in the line going into the patient, and they had a serious problem. Attempts at resuscitation were unsuccessful, and Mrs. Jones suffered a fatal air embolism. Now, from what I remember, she was maybe 28 years old and was a mother of 3 small kids. So they sued. Damages were awarded in the amount, I think it was more than $4 million by the time it was done and over with. So as the case goes on, I kind of like to get to the end. So Reader's Digest version, the cell saver tech is in the room. She's spun enough blood down to get 500 cc's back to the patient, right? She gives it to the anesthesiologist. They start reinfusing the blood. She goes to another room that she's overseeing for the cell saver machine, because at that time she's passed off the blood to the anesthesiologist, so it's now under his care. Another anesthesiologist comes in to give him a lunch break. She puts a pressure cuff around the bag and reinfuses that blood quicker, which causes an air embolism, which then kills the patient. So, kind of going down through this, and you guys can pull up this case and read it. Again, this is public knowledge. It's out there, it's in the books. Long story short, and I wish I could find where it says this. Let me come down here a little bit. Before I tell you the conclusion, in fact, I want to come up a little bit. Who do you guys think they found guilty of negligence in this case? Or if any of you have taken the healthcare or the health law and ethics class at BSU, you'll know. Anybody want to take a stab?
Was it the one that put the cuff on the blood bag?
No.
In my mind, I think I feel like it should be her because it was her being negligent. I can't even say it enough to put it on there. But yeah, but if the doctor who was overseeing the patient that left on the lunch break, I feel like it probably falls down on him.
Perfect. Anyone else wants to take a guess?
I'd say it's partially them and partially the cell saver tech, because if they're going back and forth between rooms, they should be checking the whole system when they come back.
Good. Anyone else want to take a guess? All right. I was not doing cell saver at this time, but I will tell you it terrified me when St. Al's asked me to manage the cell saver program. They actually found the cell saver tech guilty and entirely responsible. Let me see if this paper will.
That's a little messed up. I don't know.
That's crazy. Yeah, Angela, what's your opinion? Do you think she should have been found guilty, or do you feel like it was the other, like the doctors and the anesthesiologist?
Absolutely. Yeah. So as a cell saver tech, once we pass off that blood, we aren't the ones that reinfuse it, right? So we aren't the ones that hook up the IV lines, anything like that. So for me, I was absolutely astounded. And I want to say by the time this was all done and finished, it was like a $25 million lawsuit. And it was, the cell saver tech was found guilty and she was held responsible for that $25 million. And it was one of the biggest medical lawsuits in the state of Idaho at the time. There may be one past that now. And the hard part is, because this case happened and they found Jerry Kurtz guilty of negligence, that set the foundation for every single cell saver case moving forward, which was terrifying for me. So I carried liability insurance up to $50 million when I was running the cell saver program at St. Al's. I think that the jury and the court system failed in this case dramatically. I feel like if you have higher educated people such as anesthesiologists and doctors, they need to be held to a higher standard. And the fact that there was a warning on that bag that anesthesiologist did not read and failed to read and still put a pressure bag on there, that makes me sick. It really does. But I will tell you, I have caught 2 CRNAs putting pressure bags on my cell saver reinfusion bag, even though the same warning is on there. And what's hard is if Jerry Kurtz was running more than one room, so she was having to run to multiple rooms to oversee the machine, it was probably extremely difficult. And I should, what do I want to say? If the warning is right in front of their face, you would hope that they would read it, right? In all honesty. And you kind of hold them to a higher standard. Oh, they're an anesthesiologist or they're a CRNA. Of course, they won't put a pressure bag on there because they know better than that. They've been trained in school not to put pressure bags on reinfusion bags. And so for me, I was absolutely terrified. Could Jerry have come back in and taken a quick glance up and saw, oh my gosh, they've got a pressure bag on there, and then went and tell them? Absolutely. And so I can kind of see how it's multiple people's fault, but at the same time, finding Jerry Kurtz entirely guilty of this situation, and it's devastated her financially. Like, her life is ruined now because she owes this patient's family member $25 million. But this kind of goes to show you that the court systems can set foundations that in the medical world, we're like, what the heck are you thinking? There is no way this is entirely her fault, right? And that's what I want you to realize moving forward in your career. Just make sure that you follow everything policy and procedure wise to cover you. You know, maybe carry malpractice insurance. Don't do anything outside of your scope of practice. When we were preparing for our final exam last year, I had asked Jordan and Alyssa, who are, you know, obviously you guys know Jordan from your other class, and Alyssa, what they've said in the past to surgeons who have asked them to do stuff outside of their scope of practice. And Alyssa said, I'm not rude, but I'm like, you know, I can't do that. And she said, you know, she's like, I kind of come across as a joking matter, but she's like, there's no way I'm going to fire that stapler or do whatever they want me to do and risk my career and risk a lawsuit, because everything may go okay or it may not go okay. And then you'll be just like Jerry was, you know, kind of held responsible for who knows how many millions of dollars. If you guys get a chance, pull up this case and read it. It is absolutely astounding, everything that was presented. And yet one person was found guilty for the whole entire incident. So just super, super interesting. I think a large part of it, though, goes back to we have jurors making decisions with zero medical knowledge, right? So if you have a good attorney that can spin stuff in a certain direction, and you have 12 jurors that have zero medical knowledge, the jurors are going to listen to the attorneys and trust them to help educate them to make the ruling on this case. So truly, you guys look up this case. It's extremely sad for the patient. Truly a 28-year-old mother of 3. She was incredibly healthy. She was having a fairly big back procedure done at Treasure Valley, but I don't think it's a procedure that I'm sure that they probably do that procedure today. But it kind of put a stunt on CellSaver and providers wanting to use it because of this. So like every other Sentinel event, policies and procedures have changed, and we actually use a transfer bag now. So the reinfusion bag is no longer allowed according to national standards to reinfuse the patient. The blood is transferred to a transfer bag, which can use a pressure cuff. It can have a pressure cuff around it. And those transfer bags have to be labeled with a patient sticker, the time that we spun the blood, and the time that the blood expires, which I think is 4 to 6 hours in room temperature. But again, you may be involved in a case and you may think, oh, there's no way the jury's gonna, side with the patient, or there's no way the jury's gonna side with the surgeon. Just kind of be aware that you have 12 to 14 of your peers that have zero medical knowledge going into that case. And the plaintiff's attorney may be phenomenal and be able to spin that type of stuff. I'm not saying that there wasn't negligence in this case, because there absolutely was, but I really feel like that the anesthesiologist should take a large amount of this blame and negligence for putting the pressure cuff on. Most of those CRNAs and anesthesiologists are taught in school not to do that, not to put pressure cuffs on. But anyways, there's just kind of a spin on a case that I feel like didn't go very well. But it is something that you study at Health Law and Ethics at BSU for a couple of weeks if you ever take that course. It's extremely, what do I want to say? Maybe enlightening, or really opens your eyes, because my teacher at the time was an attorney. And so he was able to show, hey, everything that's decided in court isn't 100% perfect by any means. All right, does anybody else want to add anything before we hop back to the PowerPoint presentation?
That's just real terrible, man. Oh my gosh.
It kind of makes you sick, because essentially it ruined her life.
Yeah, just like, I don't know. They want to save the big guys instead of,
And that's exactly it, right? Money talks, by all means, unfortunately.
I don't know what else to say. I really don't.
Yeah, it's a little astounding. All right. Okay, so we're back to objective 8. Everybody can see this, correct?
Yes.
Okay. Surgical conscience, protecting patients from physical hazards in the operating room. And those physical hazards can be, how they position the patient. Maybe the light cord for the camera, making sure that they're not burned from that. Maybe from super hot equipment, such as what I had in my case. Understand the patient's fears and anxieties concerning surgery. There are sometimes, in the 22 years I've been scrubbing, I have had 2 different instances where the patient felt like they were going to die during the procedure, and had extreme anxieties and fears. One of those, the surgeon kind of didn't take her feelings honestly or very much to heart, and she did actually end up dying on the table. We ended up hitting a blood vessel in the sternum area. We were doing a mediastinoscopy, and the patient bled to death because we could not get the bleeding to stop. So she slowly bled out on the table as we frantically were trying to stop it. The second surgeon actually canceled the case. And he said if they feel like they're going to die, That could very well be something in their subconscious. And he said, I will not operate on a patient that is this terrified. And he said, but if they come back and want surgery, I will absolutely do it. So there's a certain extreme between patients being anxious and have an overwhelming sense of doom, right? If they have that overwhelming sense of doom, you hope that providers kind of listen to it and take it to heart and cancel the case and let it be rescheduled. If a patient is just anxious, you know, or they're scared of surgery, we talked about this a couple weeks ago, hold their hands, you know, talk to them, make eye contact. Act in a conscientious manner. So make the best decisions as if it was your parent on the table, your sibling, your child, your brother, your sister. How would you want them to be treated? Maintain professional honesty in actions as well as capabilities and qualifications. There will be times in your career where something will become contaminated at the absolutely wrong time. And it is terrifying as a scrub tech. I was doing a partial nephrectomy with a urologist who has a very strong personality. She's a great surgeon, but she can be a little terrifying in the OR just because she has such a strong personality. And we were doing a partial nephrectomy, and on those cases, you tie sutures ahead of time, and you put them into the patient. So you do it laparoscopically or with the robot, and you put them into the patient, and then when she dissects out that part of the kidney after you've clamped, so what happens is, I'm sorry, I'm kind of moving around. On a partial nephrectomy, you have to dissect out the artery and the vein, and you put little bulldog clamps on them, and you immediately start the timer because you only have a certain amount of time before the kidney dies. So once those vessels are clamped, it is a mad rush to get the tumor off the kidney and to quickly get that part sewn shut, and then you release the bulldogs, those little bulldog clamps. And so we had created these sutures even before we did our first incision on the patient. Somehow, I swear there was some sort of little, I don't know what, on my back table. And I went to grab those sutures and they were all tied together. It was like they somehow had all become intertwined with each other. And when I went to grab one, 3 of them fell below the sterile area of my back table, right? So they fell below the top of the back table, but they were still hanging on to, because they're all tied together, they all kind of got intertwined together. So I could have easily grabbed those 3 sutures and just acted like nothing happened. And I'll tell you what, it crossed my mind for a split second because I knew this urologist was going to eat me alive. Luckily, her assistant saw what had happened, and you know, obviously her eyes got wide because we're now in a huge panic to hurry up and get these sutures retied to the appropriate length. And you put a little plastic clip on the end of them. So it takes a couple minutes to make these sutures ahead of time. So anyways, my nurse saw and she quickly opened up sutures. I did take a verbal, what do I want to say, beating maybe from the surgeon because she wants the best care for her patient, right? And so obviously we had to wait an extra 2 minutes while I was quickly tying these sutures with her assistant. However, I immediately thought, if this was my brother, my sister, my mom, or my dad on the table, would I want someone to use contaminated sutures because I didn't want to have the surgeon yell at me? I am guaranteeing you something in your life, your career, will happen like this. Do not drop to the level of treating patients with subpar care, okay? You know, take those extra 2 minutes to remake those sutures. Take that extra 5 minutes to wait for another sterile clamp or another sterile instrument to come up. Just make sure that you're doing what you're supposed to be doing so that you can go home with a clear conscience at night. You don't want to do something that will keep you up at night, something that you'll have nightmares about, anything like that. Be able to walk out of the hospital with a clear head, knowing that you did the best that you could for those patients. Does that make sense to everybody? Maintain thanks, Ray. Maintain principles of asepsis. Okay, that kind of goes along with the story I just shared. Accomplish sterile technique. And commit to contain costs. It is easy to open up all instruments and items to prevent wait time. However, there are times, and maybe the majority of the time, where surgeons will not use a certain suture or maybe a certain implant, whatever it is. So to contain costs, you really want to hold stuff until you know you're going to use it 100% of the time. Have it in the room, and your preceptor, can quickly open it to you. But every single healthcare facility will really want you to watch, and be conscious of what you open. Treat patient information confidentiality by respecting the patient's rights to privacy, property, dignity, and identity. Treat patients in a non-discriminatory manner. We talked about this, I don't know, maybe 4 or 5 weeks ago. Treat every patient as you would a family member, right? Or treat every patient as a person, even if they're a prisoner, whatever it is, treat every patient equal the whole way across the board. We don't know their story. They may have false imprisonment. Listen to one's inner voice. This is huge. Learn to trust that inner voice. Learn to trust your judgment. If you feel like you need to get something in the room because maybe the patient's going to crash, or maybe the provider is pretty close to the aortic, or maybe a lumbar vessel, tell your nurse, hey, can you get me some 2-O-prolines, or can you get me the cherry aortic clamp? Whatever it is, listen to that inner voice, and you'll be grateful at the end of your career that you did, because you won't be waiting for that stuff to come into the room. Your circulator can go out and grab it and have it right there beside them. Recognize barriers to developing surgical conscience, right? Those barriers are kind of ego, your self-esteem. You don't want the providers to think poorly of you. So you're just gonna kind of, let things slide. All right, ethics. Ethics are influenced by cultural, socioeconomic, and religious backgrounds, as well as life experiences. Ethics should govern professional conduct. Ethics and laws are closely related because legal doctrines often interpret ethical concepts. Principles of ethical decision-making in clinical practice include autonomy, which is self-governing. It is you and solely you who make decisions in the operating room, right? Especially about your behavior or your actions. Beneficence, did I say that right? An act of kindness, what is the best interest of the patient? Fidelity, provide honest, responsible, and fair care. Justice, is the decision being made ethical? That is spelled wrong. Is it compatible with the law and the patient's rights? In the past, I've been involved on trauma cases that may have involved criminals or thought to be criminals. They were involved in shootouts with police. They were big drug dealers, et cetera, et cetera. And a couple of them were shot numerous times by the police. And I will tell you, sometimes that's a little tough. Treating those patients, especially for this particular one, we emptied almost the whole entire Treasure Valley's blood bank. And this has been probably 10 years ago, 8 years ago maybe. We emptied the whole entire Treasure Valley's blood bank trying to save this patient because they were bleeding out from all the bullet wounds. And I will tell you that trauma surgeon did not treat this guy one iota different than he would you know, the president of the United States or the governor of Idaho. He treated that person with the same, you know, the same level of care that he would have anyone else. But it was a little bit hard because then you realize that if your family member came in a car accident, that there may not be blood available, right, for your family member because we've just emptied it for this person that probably broke the law. Non-maleficence, duty to do no harm or allow harm by neglect. So next objective, ways of making ethical decisions. Identify the moral aspects of care, including any moral dilemmas that may occur. Gather relevant facts related to a moral issue. So, you know, do your research. There's nothing wrong with Googling stuff. I will tell you, I have Googled more procedures in the first 5 years I was at St. Al's than I did my whole entire career. And that was because I was just beginning. So don't ever be afraid that someone's going to think you're stupid or that you're dumb because you're Googling something. I guarantee you, probably whoever you're with doesn't know what that procedure is either, or maybe doesn't know what that word is either. So don't be afraid to Google. I've also YouTubed stuff, how to use a piece of equipment, because even though once a year I may have had an in-service on it, does not mean I know how to run that machine. So at St. Al's, we have brand new cell saver machines, and it's now run by a contract. I have Googled how to use those cell saver machines when we've had traumas come in, because I was trained once, you know, 18 months ago, doesn't mean I remember how to use it. So don't be afraid to take that initiative to Google and YouTube stuff. Clarify and apply personal values. Understand ethical theories and principles. Utilize competent interdisciplinary resources. Propose alternative actions. Apply codes of ethics to help guide actions. So that propose alternative actions, I was going to tell you guys, there's a lot that sometimes goes on behind the scenes in an operating room. So you may have, let's say you're doing a gastrostomy or a G-tube on a NICU baby. You've only got one in the whole entire OR. And as your circulator goes to open it on the back table, it gets dropped on the floor. So you as a class, I want to hear input. What would be some alternatives to that very vital piece of equipment or implant that is now dropped on the floor? What would you guys do as a scrub tech? It's a little too early in the program for me to ask this question. All right, no one wants to jump on this one. So I'll tell you, this has happened at healthcare facilities, and there's a couple different alternative actions that can take place. First off, you have to ask their provider, is there another size that can be used? And they may very well say, no, there isn't. This size has to be specific for this kid. I have hopped in my car and driven to St. Luke's downtown probably 3 times in the last 5 years to get products from St. Luke's that someone in our staff has dropped on the floor. So you as a scrub tech, you kind of have to be someone that troubleshoots a lot of stuff, right? Okay, so this piece of equipment isn't working. What else can we use? This clamp isn't working. What else can we use? We've just dropped this gastrostomy tube on the floor. Hey, call your EMI in the room and see if they can quickly call Luke's and see if, you know, Luke's or Treasure Valley has this particular item and we can run down and grab it. Not the best situation for the patient, right? Because that's longer under anesthesia, longer on the table, et cetera, et cetera. but if it's something that has to be done, you know, you kind of have to do best case scenario. But you as a scrub tech, your providers and your surgeons will respect you so much more if you can troubleshoot and help solve the problem instead of make the problem bigger. So apply codes of ethics to help guide actions. Choose and act on a resolutive action. Participate actively in resolving issues. And that's kind of what I just talked about. You know, be a problem solver. Apply state and federal laws governing practice. Evaluate the resolutive action to be taken. All right, next is resources for interpreting and following professional standards of conduct. Your continuing education, right? So I think it's 60 CEUs maybe. AST has just barely changed it. So you now recertify every couple years, and so you'll have the opportunity to purchase continuing education units. Purchase those units that apply to wherever you are in your career field, whether it's total joints, whether it's C-sections, whether it's ENT, whether it's robots. Purchase those continuing education units that you can use in your career. Don't purchase the easy ones. Actually grow your knowledge base, okay? Colleagues and experienced healthcare professionals. Rely upon your more experienced scrub techs, you know, your more experienced circulators. Don't be afraid to ask questions and clarify. Medical journals. Medical journals are fascinating. I love them. When you become a member of the AST, you'll get a monthly magazine that has, you know, articles in there and all of that type of stuff. The World Wide Web, kind of what I've talked about before. Don't be afraid to Google. The wider your knowledge base, the better scrub tech you will be. All right, the Surgical Technologist Code of Ethics. To maintain the highest standards of professional conduct and patient care. To hold in confidence with respect to the patient's beliefs, all personal matters. To respect and protect the patient's legal and moral rights to quality patient care. To not knowingly cause injury or any injustice to those entrusted to our care. To work with fellow technologists and other professional health groups to promote harmony and unity for better patient care. To always follow the principles of asepsis. Again, don't take the easy way out. It's not good for the patient. It may result in you being in the middle of a lawsuit. To maintain a high degree of efficiency through continuing education. Remember, education and knowledge is your friend, okay? Truly, education can make you either the top at your healthcare facility, or if you don't really care and you don't pay attention, you may have circulators and surgeons who don't want to work with you. To maintain and practice surgical technology willingly with pride and dignity. We have a pretty cool job. When I started at St. Al's when I was 18, I already had a degree in sports medicine because I'm kind of an education nerd. But anyways, I started at St. Al's just as an ORA and an orderly. I kind of got tired of working with athletes, which is funny because I was an athlete. Anyways, so I went in there and I was an ORA, and I just kind of wanted to learn what happened in the operating room. And I sat there and watched scrub techs, and I thought, what a cool job. We are right next to the surgeon. We can either make their cases go super slick, super smooth, or else if you're not that great of a scrub tech, you can make that case last twice as long and cause frustrations. So I'll always be proud of being a scrub tech. I think it's one of the coolest jobs out there. And you get to see a lot of different stuff, and you have a lot of different opportunities. To report any unethical conduct or practice to the proper authority. To adhere to the code of ethics at all times with all members of the healthcare team. Standards of professional practice. Standards of professional practice describe activities related to quality assurance, education, ethical behavior, and accountability. Standards are set and maintained by each medical facility to provide guidelines for patient care and safety. Personnel must adhere to established policies and procedures to protect themselves, other workers, and the medical facility from litigation. So I know policies and procedures is kind of dry material and you hate reading it, but it's best if you know what the policies and procedures are of your facility. So we had a case where, again, we had a patient on the table. Come to find out, we didn't have the implants needed to do the procedure, but St. Luke's Town did. So we called them, borrowed them. But then we found out that they would need to be rewrapped and re-sterilized to come into our facility. So that was something we didn't know because we weren't up to date on the policies and procedures. Also know your staffing policies and procedures, right? You know, how many absences can you have? How many times can you call in sick in a certain amount of time? All of that stuff will prevent heartache, frustration, and stress down the road. The following are standards of practice that should be followed by the surgical technologist. Teamwork is essential for perioperative care and contingent upon interpersonal skills. Always be a good team player. You know, if you're not in a room and you're floating, go help out your teammates. Go help clean the room. Go help open. Be there to help clean up. You know, take their instruments off the back table and hang the laps and sponges. Pre-operative planning and preparation for surgical intervention are individualized to meet the needs of the patient and the surgeon, which we talked about maybe like 4 or 5 weeks ago, but that patient may need extra padding, right? If they are a bariatric patient, you may need a certain type of bed. The last thing you want to do is put a bariatric patient on a bed that they weigh more than the weight limit of that bed. Always make sure that you have the correct equipment in the room, you know, whether that be a certain type of arm board or stirrups or, you know, whatever that is, leg holders. Make sure that it meets the needs of that particular patient, but it's also what the surgeon needs. And that'll be on your preference cards. Preparation of the surgical suite, clinical area, and all supplies and equipment will ensure environmental safety for patients and personnel. Are you wearing lead? You know, if you're going to be doing x-rays and using the C-arm, that type of stuff, make sure that you guys are taking care of yourselves as well. Application of basic and current knowledge is necessary for proficient performance of assigned functions. Each patient's right to privacy, dignity, safety, and comfort are respected and protected. Again, you may have a patient that wants an all-male crew or an all-female crew. Every patient is entitled to the same application of aseptic techniques within the physical facilities. All right, any questions?
No, it makes sense.
Does it make sense?
No, it makes sense. It makes sense.
Good. I feel like we covered a lot of terms, which again, are kind of foreign to me. So I've been researching them for months on end. So I want to make sure that everyone fully understands them. Like I said, this test is difficult. So please, please, please take the time to fully understand the material, be able to apply it, because there's a lot of situations, or there on the test, there's questions that incorporate situations. Does that make sense? So kind of some terms I want to review and cover. Malpractice insurance. Insurance that protects a professional person, such as a physician, surgical tech, or dentist, against an act of negligence. Hippocratic, having to do with traditional medical principles that require physicians to follow a high standard of moral conduct while practicing medicine. Negligence, failure to use care that a reasonable and prudent person would use under similar circumstances. So national standard of care, did they not provide the same type of care or treatment that is a national standard of care? A sentinel event, an unexpected or unanticipated event in a healthcare setting that results in death or serious psychological or physical injury to a patient. Did they fall off the bed? Was an idiot scrub tech like myself gave the surgeon a hot bar that then was dropped on the patient? Root cause analysis. Oh, and I was going to tell you guys this. So we did, of course, it was a sentinel event when the surgeon dropped that hot bar on the patient. Root cause analysis, after risk management came in, St. Alphonsus actually decided to buy more instruments so that we would not have to process them so quickly in between cases. So it was a positive outcome for us as staff because we didn't have to handle extremely hot metal instruments, but they did a root cause analysis, found out for patient safety reasons, they needed to purchase more instruments. Ethics, principles that govern human conduct and values. Here's the other thing. I always think that it's a big compliment when a coworker requests that you be on their case. So, let's say that I'm having surgery and let's say, what am I having? Maybe I'm having a total knee done, right? And what's one of the biggest kind of like most scary or detrimental complications of a total joint is infection. Because with infection, you may actually end up losing that joint. And I don't mean amputation, which amputations can occur, but they will actually end up fusing that joint because it's lost so much bone and tissue that they cannot make a joint out of it, right? So infections and totals are absolutely terrifying. But I'm having a total hip or a total knee, whatever it is, some sort of total joint. And I know that Lindsay is absolutely incredible with her sterile technique. I've worked with her before, and she doesn't cut corners. She always puts the patient first. And so I'm going to request that Lindsay be in my room. As a scrub tech, that's one of the greatest compliments that you will ever receive, is to have a coworker request you on their case. So aim for that type of goal in your career. Would a coworker request for me to be on their case because they know that I will provide exceptional patient care? All right, any other questions, concerns? Are you guys so excited to be done with the semester?
A little bit, yeah.
I'm excited for stuff to be in person.
Oh, amen. Amen, amen, amen. And I think everything that Jordan and I have taught you this summer, or the material that we recovered, will click so much more once you're able to do it and see it in person. So I agree. You will love the lab. Okay, I'm going to go over a couple of these, and I'm going to go over a couple of these because I want you to understand that perhaps they are on your test, okay? So I kind of covered one earlier. Res ipsa liquitour is a Latin term related to the following. Can I tell you, I have said that word probably 150 times and watched it on Google just to be able to hopefully say it maybe correctly.
Will you say it again?
Oh, say it again. Cool. Yeah. And I've been sweating bullets during this section because some of these words terrify me. Res ipsa liquitour. And that is Latin. So res ipsa liquitour is a Latin term related to the following. Okay, so the definition of that phrase, literally a thing that speaks for itself. A defendant is guilty of negligence without the need to show direct involvement. So I want you to remember that. If by chance a retained surgical instrument occurs on a case, that is a res ipsa liquitour, right? Because there's no doubt that that instrument was left in the patient, or a lap. They take the x-ray, oh, look at that. There is a Kelly, or there is a Carmalt, or a malleable retractor left in the patient. Okay, so it speaks for itself. Nobody has to prove anything. The plaintiff's attorney doesn't have to prove anything. No, it honestly speaks for itself. Okay, if a sentinel event occurs, the process in which that sentinel event is addressed is that the sentinel event occurs, then you have to write an incident report, and then there's an investigation by risk management. And during that investigation, they'll do a root cause analysis, and then policies and procedures will probably be implemented to prevent a sentinel event like that again. So what is an intentional tort? Anyone read the material?
I did, but I can't remember it right now. Like intentional tort, I can't remember. Yeah.
You're all good. Okay, so if it's unintentional, here, I'll put it this way. First degree murder and second degree murder. What is the difference? Do you guys know? So it's usually premeditation, right? So first degree murder, did they premeditate? Did they plan out the murder? Second degree murder, maybe they didn't plan out the murder. It just happened, right? They didn't think about it. So here's a question. All of the following would be an example for unintentional torts. If I want to assault someone or commit first degree murder, that is not an unintentional tort, okay? Because I am purposely hurting that person. So if you have fire negligence that is not associated with risk management, do you guys all know what neutral zones are? I think that's material covered in Jordan's class maybe 4 weeks ago, 3 or 4 weeks ago. So a neutral zone is a place where sharps, right, whether it be your blades, your hypos, your suture, is placed on your Mayo stand or your back table. And sometimes they'll use like an orange little meshy type thing, and that's designated as your neutral zone. So if your surgeon is using a knife, he knows to put it on the neutral zone. So know what a neutral zone is. I kind of talked about if you're eating lunch in the cafeteria with your coworkers or your buddies, don't talk about a surgical procedure or state the patient's name, right? Because that's a HIPAA violation. Let's say that a surgeon asks you to give local after that provider has already broke scrub. You cannot perform that action because it is outside of your
scope of practice.
Yay! Woohoo! Awesome. Whose responsibility is it to obtain the consent? I will tell you who's responsible.
Or the RN?
Yes.
Or?
Yeah, so I was going to tell you, that's a super hard one. the RN has to verify that the consent has been given before they come back to the OR. But it is actually the surgeon's responsibility to obtain the informed consent. And that normally happens in their office. So just remember that. The responsibility of obtaining the informed consent is the surgeon, okay? The circulator double checks it prior to bringing the patient back to the room. An intentional tort pertaining to surgical patient care. And we've had these cases before at St. Al's. I think that these are also could be issues maybe at nursing homes or long-term facilities. And those are restraints, you know, and you really, really have to do your check marks if you're going to use patient restraints. Make sure that they meet every single one of those areas so that restraints can be used. If a wrong site surgery is done, what favorite phrase of mine would apply? So we talked about it. If an instrument is left in a patient, it was what? Res ipsa liquitour. If a wrong site surgery is done, such as I go in for a right knee scope, but they do a left knee scope, again, the attorney does not need to prove anything because I've got the scars on my left knee versus my right. So again, it's a res ipsa liquitour, a thing that speaks for itself. The attorney.
I just didn't want to try and say it.
Oh, thanks. That's great. Yes. Come on. No, but that's awesome. I would have avoided that too. We should just abbreviate it somehow, RI, or call it the liquor phrase. The phrase departure from the standard of care is which legal term? This one's easy. Anybody know? Anytime you go to court proving that the surgeon was negligent, what are they going to do? They're going to compare him to another provider or another surgeon and the standard of care, okay? So negligence is all about deviating from the standard of care. If you have a surgeon that behaves in a unprofessional way and causes harm to someone else, such as kind of I talked about that surgeon, which again, it wasn't anyone local. It was, I think, somewhere back maybe in the East or in the South, carved his initials in a woman's uterus because he thought it was funny. Malpractice, okay? When I had to go before attorneys and my legal team at St. Al's and answer questions, what is that called? Does anybody know?
Is it the
one of those words up
thing,
there?
or however you say it?
Subpoena? Nope.
Yeah.
A subpoena. A subpoena
Deposition?
is deposition, exactly. So a subpoena is actually when I receive a document in the mail, or more than likely you'll be served a subpoena to show up in court.
Okay.
Does that make sense?
Yeah, to be honest with you, I haven't read the material yet, so I'm kind of just guessing.
It's all good. And truly, if those words aren't in the book, kind of like I said, Google them just so that you get a little bit better understanding. Do you ever intentionally leave a foreign body or an instrument in a patient?
No.
No. So that would be an unintentional tort. Okay. Ooh, this one's a good one. Which type of consent applies when emergency circumstances exist when reasonable providers believe that a patient would agree to treatment, even if no form was signed or verbal permission given? On the trauma team, we see this a lot, right? Patient comes in, they have a severe head injury, they're bleeding from their spleen or their liver. There's no way that we can get a consent. So what type of consent? Hold on, I'm looking for it. See if it's in one of our words. Legally, can we assume, what's another word for that? That a patient would agree to treatment?
It's implied consent.
Yes! Woohoo! Nice. Did you read the material?
No, not yet.
What? Are you a legal assistant?
No, I've just had to take a lot of medical classes so far.
Awesome. Well, strong work. All right. A special consent form would be required for which of the following situations during a hospital admission? Either a chest x-ray, phlebotomy, respiratory therapy, or a surgical procedure.
Surgical procedure.
Oh.
Nice. Good job. Nice, nice. So in 2004, which of the following agencies created the Do Not Use Abbreviation List? So I will tell you, like when nurses are making out pathology slips, they cannot use some of the abbreviations, and that's because it creates confusion in patients' charts. So Joint Commission actually came out with a list, a do not use list, and said you cannot use these abbreviations in medical charts, you know, and when nurses are charting and all of that type of stuff, you cannot use those abbreviations because it can be construed as something else and may cause miscommunication issues in patients' charts, which then results in patient safety issues. All right, I'm just quickly looking over your test, seeing if there's any questions that I wanted to go over with you. And this one's on your national exam. Or it can be, because there's a large list of questions. Which of the following surgical patients would be legally authorized to sign an informed surgical consent based on medical practice acts and state laws? So your choices are pre-medicated competent adult, adult in a persistent vegetative state, an emancipated 16-year-old, or a foreign language speaker without an interpreter. Remember how I talked about Google your words? So the answer is an emancipated 16-year-old. This one we've covered a couple times. Which of the following pertains to a patient's wishes about medical treatment and self-determination in the event of incapacitation or inability to communicate? Everyone better get this one right. You remember we just kind of talked about this at the beginning of class. advance directive. And it doesn't matter your age, whatever. Make sure you all have advance directives, just to take the pressure off your family. Which of the following terms best describes the process of keeping thorough, accurate, and legal records of a patient's medical care? Anybody have any idea?
Angela, can you repeat the question, please?
You bet. Which of the following terms best describes the process of keeping thorough, accurate, and legal records of a patient's medical care? I'll give you the options: accountability, consent, documentation, or liability. Any ideas? Documentation. Nice. All of the following carry the force of state or national legal enforcement except, here are the options: Health Insurance Portability and Accountability Act, Patient Self-Determination Act, Scope of Practice, or Implementation of the Neutral Zone. Out of all of those, which one is not going to be legally enforced?
The neutral zone one.
Perfect. Absolutely. The American Hospital Association replaced its Patients' Bill of Rights with which of the following? And they replaced it with their Patient Care Partnership. All right, do you guys want to do a few more, or do you want to be done?
A few more, please.
Okay. The most common types of patient care errors committed by operating room personnel, including negligence and malpractice, are categorized as, and those are unintentional torts. According to the Joint Commission's definition regarding consent to surgical intervention, which party has autonomy? Autonomy. Sorry. That's the patient. The legal term that identifies the knowledge and skills required for a profession and describes a healthcare provider's core accountability based on education, experience, and credentialing is, that one's scope of practice. Ooh, here's a good one. Verification that educational programs meet minimum accreditation standards is done by, and we mentioned this earlier, the CAAHEP. So the CAAHEP is the one that accredits the CWI-AST program. Graduates of CAAHEP or ABHES programs are eligible to sit for the CST or CSFA examinations administered by, and that's NBSTSA. So they're the ones that administer the national exams once you have gone through an accredited program. Which legal doctrine would be most applicable in a case involving failure by the RN and CST to do proper surgical counts, resulting in retention of a foreign object and the surgeon being found not liable? And that's the doctrine of borrowed servant. Kind of the captain of the ship.
Surgeon?
Yeah, so here, I'll read the question again. When legal doctrine would be most applicable in a case, which legal doctrine would be most applicable in a case involving failure by the RN and CST to do proper surgical counts, resulting in retention of a foreign object and the surgeon being found not liable? And that's doctrine of borrowed servant. Who can tell me the motto of AST? You can even spell it. I won't even make you say it.
Isn't it something like the patient first or something like that?
Perfect. What is it? What is it in Latin, right?
Need, yeah.
So it's ager primo.
Ager primo, okay.
Ager primo, literally the patient first.
Ager primo, okay.
So here's another question. Which of the following types of law is established on the basis of previous court decisions? So I want you to think about the Cell Saver case, right? So that's common law. A type of law that has established a foundation by previous court decisions, and that's called common law. The degree to which an action could be anticipated to cause injury. That's foreseeability of harm, right? Or your doctrine of foreseeability. I just barely covered this one, but what organization verifies the educational programs for surgical technology have met the minimum standards? That's your CAAHEP, your Commission of Accreditation of Allied Health Education Programs. Which of the following is the guiding principle of the Hippocratic medical ethics? That's up on your screen. What is it?
Primum non nocere.
Nice. Strong work, Alessandra. Okay. I think I've given you enough. So again, this test is difficult, and I'm telling you that because I want you to prepare for it, okay? Read the book, read the chapter, do your module, watch the AORN video, look at the questions in the packet for the AORN video. Make sure that you know the correct answers. Any questions, concerns regarding discussion board? Did I already ask you? Does everybody have their scrubs?
I do.
Yes.
Perfect. Make sure, okay, make sure your scrubs are embroidered and ready to go for orientation, okay?
Okay.
You saw the announcement about the immunization records. Do not send those on to Mona. They'll tell you what to do with at orientation. And hold on one sec. Mona had wanted us to send out another announcement. So let me go over that quickly. Please check your fall registration status. If you're not registered for classes, please contact Emily Sprite at emilysprite@cwi.edu immediately to ensure your spot in the program. And she said, and then later on she messaged and said, it looks like only one person hasn't registered so far. So if you're that one person, make sure that you check your fall registration. Okay. So again, review is next Tuesday at 9 o'clock. Jordan and I will both be in the lab reviewing for your final. What else? Anybody else have any questions, concerns?
Yes.
Did everybody?
Sorry. How can I know if one case is civil or criminal? It's correct if a civil is involve just to private party. Do you understand?
Hey, Alessandra, say it one more time.
Yeah, sorry. I want to know, how can I know if one case is a civil or criminal? Which is the difference?
Is it how do you know if a case is
Civil or criminal? I just write down here.
yeah, I'm sorry. Will you write it down?
I think she's asking if it's
asking
civil,
if
the
it's
difference
criminal.
between a civil and a criminal court case.
Yeah.
Yes, thank you.
Got it.
About the study case number 4, group 4. So I read the story. How can I answer to the first question, is a civil or criminal? I want to make sure.
Are you talking about your discussion board?
Yes.
Ah, got it. Which group are you in?
Group 4.
Okay, let's pull it up. And Alessandro, have you Googled both of those yet?
Yes, I searched and I found that the civil is when the action include the two private parts, and not in the crime is not against the state or federal city or something else.
So I will tell you, on these discussion boards, there is no, we're not going to say this is wrong, this is right. Does that make sense?
Yes.
As long as you made the post and you back it up with knowledge, and your opinions, we're still going to count it right. But part of those questions, though, is you just doing the research to answer them.
Oh, okay.
Does that kind of make sense?
Mm-hmm. Okay.
Okay. Yeah. So don't stress too much that it's right and wrong. Do the research on it and then present that in your post.
Okay.
All right. Any other questions, concerns?
Hey, by chance, do you have the schedule for when fall starts? I seem to have lost mine.
I do not, but if you email Mona, she'll quickly send it over. She's pretty much on top of stuff.
Okay, cool. Thank you very much.
Yeah, you bet. I'm pretty sure that it's lecture Monday through Thursday, with a couple of those days probably being lab, and then you have tests on Friday. And I've already had one student ask if they can work on Fridays. The hard part is that your tests on Friday are designated at a very specific time. So it'll be like Mona's test is scheduled from 10 to 12 on Friday, or Eric's test is scheduled from 8 to 10 or whatever. So I wouldn't recommend working on Fridays, even though you won't be in class. Oh, there you go. Carly will send it to you.
Yeah, Carly, if you could. Thank you. Oh, dope. Here, let me.
Oh, nice.
Print that off.
Thanks, Carly.
Thank you. Let's open up a Word document. Yeah, I don't know where I left mine. I had it and then just disappeared.
It's all good. So on Tuesday and Thursday, you'll see that third week in November is 6:30 to 3. And that week is actually the week that you start coming into the hospitals and the healthcare facilities. So from the third week in November until Christmas break, you will be in the hospitals Tuesdays and Thursdays.
Do you know when they'll have us have our lunch?
Do I know when the hospitals will have you have your lunch?
No. During the classes.
When will you have lunch during, like, in class time?
Yeah, in class.
I would say that that's probably varied. It kind of depends upon how the material is going. And so they may say, okay, anyways, this is what we did last year and last semester. They'll say, okay, we're going to go ahead and break right now and, go grab some lunch, and then we'll see you in a half an hour. So I don't think that there's designated lunch times, Ray. I think it's
when
it'll be, yeah, exactly. It'll depend upon how the class is progressing and how the lectures go.
Okay, cool.
I think on Wednesday, like 9 to 12:30, so I would bet lunch would be from 12:30 to 1. On Mondays, right, I would bet you won't do lunch, but anyways, I would guess you wouldn't have a real solid lunchtime except for maybe Wednesdays.
Yeah. All right, that makes sense. Thank you.
All right. You bet. All right, it's been a pleasure. I'm excited to see you guys in the fall. I'm excited to watch you progress and do well. We'll stop recording, and we will plan on seeing you next Tuesday at 9 o'clock. Have a good rest of your day.